So let's transition to urinary incontinence. To brainstorm for a minute, what is urinary incontinence? And what are some of the consequences of urinary incontinence? Why is this relevant? It's relevant because we practice evidence-based medicine. It's relevant because our assessments and intervention should translate into an improvement in quality of life and an improvement in life expectancy. Another way of saying that, it should translate into a decrease in morbidity and mortality. And this should be guided by the principles of the 4 M's framework. This is also relevant because incontinence is manageable. Our interventions and assessments can treat urinary incontinence, so it's relevant. It's preventable also. What's the definition of urinary incontinence? Urinary incontinence is involuntary leakage of any amount of urine. Now, this is important because urinary incontinence in the older adult may not represent a specific pathophysiologic entity. Compare this to urinary incontinence in a younger adult. In a younger adult, urinary incontinence is linked or caused by a specific pathophysiologic problem, or it may be caused by some sort of damage to the lower urinary tract or the pelvic floor. That's not the case in an older adult. In an older adult, urinary incontinence is associated with multiple underlying problems, either occurring individually or in combination. So, for example, urinary incontinence in the older adult is linked towards multiple comorbidities, or it may be linked towards medications, or it may be associated with functional and or cognitive impairment. So urinary incontinence is a classic geriatric syndrome. It is a classical geriatric syndrome in which multiple risk factors interact with one another, and they interact also with other modulating factors to produce a clinical phenotype. Okay? Overactive bladder is a term used to describe uninhibited bladder contractions. Okay? Overactive bladder leads to urgency. Okay? And this urgency may be with or without urinary incontinence. There are 4 types or 4 categories of urinary incontinence. The first is urge urinary incontinence. In urge urinary incontinence, the older adult has a compelling urge and often a sudden urge to void. There's also stress urinary incontinence. In stress urinary incontinence, there's leakage associated with increased intra-abdominal force. Increased intra-abdominal force that's generated by maybe coughing or sneezing or laughing and or physical activity. Okay? Then there's the mixed picture. Urge incontinence in combination with stress urinary incontinence. And finally, there's urinary incontinence related to incomplete or impaired emptying of the bladder, which is sometimes termed overflow urinary incontinence, and it's related to an increased post-void residual. It's characterized by an increased post-void residual, often with symptoms of dribbling small amounts of urine. In overflow incontinence, typically the post-void residual volume exceeds 200 milliliters of urine. What are some of the risk factors for urinary incontinence? And there are a variety of them. It includes cognitive, environmental, functional, medical, medications, dysfunction to the lower uterine tract, and others. So, underlying medical conditions may increase the risk of developing urinary incontinence. For example, obesity, functional impairment, injury to the lower uterine tract, mobility problems, manual dexterity issues. Cognitive impairment, for example, in the setting of dementia, where the individual may not remember or may not sense the urge to go void. Medications can increase the risk of urinary incontinence. Environmental barriers, availability and access to the restroom, and motivation. These are all risk factors contributing to urinary incontinence. In older adults, continence depends not only on lower uterine tract function, but also on the ability to toilet, which requires sufficient physical function, cognitive motivation, and availability of toilets. Let's consider the prevalence and consequences of urinary incontinence. The prevalence increases with age. In addition, the prevalence increases with the need for assistance with activities of daily living. As much as 30% of older adults above the age of 65 years, report urinary incontinence. And as much as 70% of individuals in long-term care facilities report urinary incontinence. Urinary incontinence tends to affect women greater than men at a 2-to-1 ratio until the age of 80 years old. The cost associated with urinary tract infection, the cost and burden, there's an increase in caregiving time, there's an increase in caregiver burden. There's also an increased economic burden to the count of $26 billion annually. Urinary incontinence significantly impairs quality of life and general health. It's associated with an increased risk of morbidity. It's associated with an increased risk of a decreased sense of emotional well-being. In the setting where social activities may be maintained, it's associated with an increased risk of just the burden of coping and an increased risk of embarrassment and an increased risk of poor self-perception. Urinary incontinence also impacts independent functioning. Urinary incontinence may lead to social withdrawal and social isolation and even depression. So what are some of the causes? Or what does urinary incontinence contribute to? It impacts the general health. So it may increase the risk of developing dermatitis or cellulitis, increase risk of pressure-induced skin injury, increase the risk of urinary tract infection, increased risk of falls and complications of falls, increased risk of sleep deprivation, increased risk of social withdrawal, sexual dysfunction, and again, it's associated with an increased risk of depression. How do we manage urinary incontinence? The general goals or principles include decreasing pain and suffering, improving social role, increasing emotional and interpersonal relationship, improving sexual function and relationships, improving self-perception, and finally, minimizing the financial burden. Specific treatments may include lifestyle intervention, behavioral therapy, medications, and or surgical intervention. How do we treat urinary incontinence? Treat the underlying cause. Treat the precipitating agent. Correct contributing factors. Eliminate contributing factors as much as possible. Behavioral therapy may include prompted voiding in patients with cognitive impairment. Prompted voiding. Bladder training. Medications such as oxybutynin and tolterodine are beneficial. Minimally invasive procedures and the surgery are also beneficial. In terms of primary prevention, lifestyle modification is indicated, weight loss to reduce the risk of stress urinary incontinence, avoiding excessive or extremes of fluid intake, avoiding caffeinated beverages, avoiding alcohol, and avoiding smoking. Supportive measures may include pads and protective garments, and there is a role for condom catheters, which is superior to indwelling catheters in that indwelling catheters may increase the risk of infection and other complications.